So it's a warm welcome to ICMLF Regional Discussion Groups. My name is Dr. Amma Benakwesi-Kuma, and I'll be moderating the session. ICMLF is International Chronic Myeloid Leukemia Foundation and has a number of very innovative programs that is helping the CML community of physicians and scientists. One of such programs is raising the bar of CML management through CML education. And in terms of education, we have ICMLF conversations, we have publications, we have a knowledge center. And in terms of management, there's been more than 200 clinical preceptorship programs. And I'm proud to say I'm a recipient of one of those preceptorship programs, and it's just amazing. In terms of research, harnessing the power of global research, we have ICMLF Genomics, we have Treatment-Free Remission Alliance, and then we have CML Hepatitis B Survey of Practice. We have pediatric CML treatment in low and middle income countries, and of course, many more. So today, what are we looking at? We're looking at attempting TFR in resource-constrained settings, and we're also looking at BCR ABL monitoring and intervention, slow responders current guidance. A few housekeeping rules. Please remember to mute yourself so that you do not disrupt. And then you can have your questions in your chat. It will be answered. And of course, when we open up for questions, you can unmute and I will moderate that, and then you can ask your question. So that is for the housekeeping rules. So we're going to start off with BCR ABL monitoring and intervention, slow responders, current guidance. And to do this, we are privileged to have Professor Hemant Malhotra. He's from Ram Cancer and Super Speciality Center, Mahatma Ghandi Medical College Hospital in India. Thank you so much, Prof, for joining us today. We have Dr. Ehrem Haile from Addis Ababa University, and he's from the Ababa Tertiary Referral and Teaching University Hospital, Addis Ababa, Ethiopia. Thank you so much, Ehrem Haile, for joining us today. So we're going to hit the ground running with today's session, but would want to remind you that the next session will be 12th November, and we're looking at CML and pregnancy in resource-constrained settings with Professor Otiono Abinya from Kenya and Professor Mike Morrow from USA. And then we're going to look at overcoming challenges to adherence to therapy, and it's going to be by Dr. Zavo from Czech and myself from Ghana. So please save the date. And these are a few of the links to some of the things I've already talked about. Thank you so much. So now we will begin straight away with a session on BCR ABL and slow responders. And so would invite Dr. Haile to give us the presentation, after which we would have a discussion, and Prof. Malhotra would also give us his perspectives, and then we will open the floor for questions, and then we will move on. So over to you, Dr. Haile. Please share your slides. Hello, can you hear me?
Okay, thank you. You can see my slides, right?
Yes, we can. Thank you. Please go ahead.
Okay, thank you, Amma, and thank you everyone for having me. And again, I would like to welcome everybody for this second ICMLF regional discussion on CML. And my point of discussion today is going to be on the BCR ABL monitoring and intervention, with particular focus will be on slow responders and how shall we go about it, especially in resource constrained setups. I have two cases for today that would help me to reflect on this topic. And I will discuss the first case and I will go to the next after discussion and reflection from Professor Hemant. And I have few introductory slides, and the burden of CML in resource constrained setups is very significant. More than half of these patients are known to live in resource limited setup. In our country, CML is the most common chronic leukemia, and imatinib has been introduced in the past couple of decades, and it has revolutionized the outcome of CML in our setup. Our patients are very young, just like the other African countries. The median age of diagnosis in our setup is around 37. And we have access to imatinib and all the other second and third line BCR ABL inhibitor TKIs from access from the Max Foundation. And most of our patients actually tolerate the treatment very well. And up to now, we have diagnosed like more than 5,000 patients with CML in the past 2 decades. And a significant number of them are still on treatment in our setup. These are some of the challenges that we face in our setup, similar to the other treatment centers in Africa. We have an availability of important diagnostic follow-up investigations. We have awareness and adherence issues in our population, and lack of decentralized CML care is compromising outcome in our setup still. And there is also significant economic limitation from our patients' side on follow-up. Delayed clinical presentation is still a challenge that affects treatment outcome on TKI. In CML, significant number of patients present at the later stage. And for this group of patients, we don't have availability to a transplant, and still is a challenge. This image shows the hematology team in our country. It's a clinical hematologists practicing in our country. We have like 10 hematologists caring for CML patients in our setup. Okay, and because of these significant limitations, now we have issues cropping up with updates and giving update therapy for our patients with CML. And with this regard, now we have a recent update from the European Leukemia Network 2025 in treatment and follow-up of patients with CML. And this update had some important highlights. One of them is this update stressed on the importance of molecular monitoring of patients with CML, especially in the first 12 months, to assess the depth of response on the different TKIs and to also decide on changing therapy. And they stress that these follow-up milestones are very important. And but instead of just following these predetermined times of BCR ABL measurement, just to change the therapy, they also stress that the kinetics of therapy and progressive decline in the BCR ABL level should also get focus, instead of just relying on single measurement at 3, 6, and 12 months to change therapy. And there are so many conditions, including comorbidities, toxicities, and the aim of therapy, TFR versus PFS, in terms of changing the therapy. And there are also some changes in the phrases that now they are used in the recommendation. Now failure should be changed to like unfavorable, because the kinetics of therapy should also be considered in order to change therapy. So in our setup, like we don't have routine access to BCR ABL, and most of our patients, they don't have a BCR ABL monitoring levels at 3 months. But how shall we go about patients who are labeled as slow responders in the recent update is going to be my area of discussion today. And my 2 cases, more or less, are going to revolve in this area. So I'll go straight into my first case. And This is on a 39 years old male patient. We diagnosed as CML chronic phase early 2024. After he presented with progressive splenomegaly related symptoms, CML chronic phase, and after initial few weeks of cytoreduction with hydroxyurea, we started imatinib, 400 milligram. He fairly tolerated the therapy, apart from like some grade 1 and non-hematologic intolerances, but there was a good adherence reported. And patient was on follow-up every 2 weeks, and by 3 months, the patient achieved a complete hematologic response. And we determined the BCR ABL at 3 months, and this patient had a P410 protein transcript, and the level was around 23.4. As you can see, it is well above 10%. And this is the follow-up in the first 3 months of therapy. The patient achieved a complete hematologic response, like after 2 months of therapy, but the BCR ABL level was like 23.4. We try to assess his adherence to therapy, which is very good. We look for alternative drugs which can have drug-drug interactions, and the patient didn't have any other alternative, the other drugs which could interact with the TKI. So we just continue therapy with the same dose of imatinib, and we continued well up to the 6 months of therapy. Patient was followed every 4 to 8 weeks. This shows the CBC parameter at 4, 5, and 6 months of therapy. As you can see, the patient remained in a complete hematologic response, but by 6 months of therapy, we again repeated the BCR ABL, and the level was around 6.4%. It was above 1%, but again, we continued therapy in this patient with the same dose of 400 milligram daily of imatinib, and we continued follow-up every 6 months, assessing his hematologic response, adherence, and tolerance to therapy. And we didn't have any issues. And we continued therapy to 1 year of 1 year milestone. We updated the CBC. The patient was still in a complete hematologic response, but we repeated the BCR ABL is 1.8%. As you can see, there is progressive steady decline in the BCR ABL starting from the 3rd months of therapy to the 6 months to 12 months. But by 12 months of therapy, it was above 1% still. So we considered a possible CML disease with a primary imatinib resistance, given the fact that the BCR ABL stayed above 1% after a year of therapy, and we diagnosed the treatment failure. KD, kinase domain point mutation, was considered, but because of economic constraints, it was not able to be, patient was not able to have it done. So we changed the therapy to 2nd generation TKI, which is nilotinib. 400 milligram BID was decided after 12 months of therapy, and the patient started imatinib. He tolerated the therapy very well, and there were no issues reported. And first month and second and third month, the patient stayed in a complete hematologic response. We are not able to do the BCR ABL at 3 months of therapy after initiation of nilotinib, but we did it after 5 months of therapy, which is a few months back, a few weeks back actually. And the BCR ABL level after 5 months of initiation of nilotinib, and after about 17 months of initiation of therapy, the BCR ABL now was less than 1%. It was like 0.6%, decreased from 1.8 within 5 months of nilotinib therapy. So we saw him last 5 weeks back, and the patient was tolerating the therapy very well, and he was adherent to therapy, and he was in a complete cytogenic response. And we plan to continue on the same line of therapy, monitoring his BCR ABL and hematologic response every 6 to 12 months. So in this particular patient, as you have seen, the BCR ABL was progressively showing a steady decline, but patient was persistently in a warning zone at 3, 6, and 12 months of therapy. So this is all I have about the patient, and now I'll open the floor for a discussion, and I also call upon Professor Hemant to reflect on some of the discussion points that we have chosen. So these are some of the points that I thought would be important for this particular patient, but you can reflect with your own ideas. So in light of recent evidences, also according to like the 2025 European Leukemia Network update, how shall we approach patients who are persistently in warning zone as 3, 6, and 12 months, which previously were labeled as a treatment failure? And so that's one of the points. And the other is, in this particular patient, do you think treatment should have been changed earlier with a KD mutation? Or do you think the change of therapy at 12 months of therapy, just as we have done, do you think is justified, or it should have been changed early? Or else we should have continued on the initial imatinib therapy, despite the fact that the BCR ABL was above 1% at 12 months, considering the fact that the BCR ABL was showing progressive steady decline? And how individualized should you think therapy should be changed in a patient with CML who was persistently in a warning zone, but no evidence of failure, considering the steady decline, comorbidities, age of patients, and also the aim of therapy? So these are the points that I would like the audience to reflect on. But first, I'll open the floor for Professor Hemant to reflect on the first case.
So thank you, Dr. Ehrem. Very, very nice case and very commonly seen issue and problem. Can you tell me the age of the patient one more time?
What was the age?
So 39. Okay, so relatively young patient. At diagnosis, the BCR ABL was about 23, and then at 6 months, 6.4, and at 12 months, 1.8. So classical definition, as per the earlier ELN guidelines, this patient would be considered appropriately managed, considered as imatinib resistance, and appropriately changed to a second generation TKI with an optimal molecular response to the second generation TKI. So all this recommendation was primarily based on one trial, one basic trial from the Hammersmith Hospital, David Marin's trial, that if the patient doesn't have an optimal response at 3 months, an optimal response meaning BCR ABL less than 10%, then that patient will have a 30 to 40% reduction in his overall survival at 5 years. So now we have two very large databases, one from MD Anderson and one the CML4 study, and we have long analysis now. We have 10-year analysis now, and we are beginning to believe that these milestones in the earlier ELN guidelines were too tight, and if there is a gradual continuing fall in the BCR ABL transcripts, then rather than label this patient as resistant to one TKI, you can label this patient as a slow responder, and you still have the option of continuing the same TKI, maybe the first generation TKI or the second generation TKI, which was started up front. So if I were managing, and these things are reflected in the 2025 ELN guidelines, that you don't lose very much if you continue these slow responders on the primary TKI and wait for another 3 months or another 6 months, and then make your final decision. So I have some data with me just now. So at 6 months, if the BCR ABL transcripts are more than 10%, then the 10-year overall survival is only 10% less than the patient who is having a so-called optimal response. And if at 12 months it is more than 10%, then you have a 30% decline in the overall survival. So possibly the 6-month cutoff, the 12-month cutoff, more than 10 at 12 months, probably would be more reflective And there are certain parts of the world, particularly in my country, in India, where we have generics for the first and all the second generation TKIs, but the generic for the imatinib is about one third the price of the generic for the second generation TKI. So we are automatically a little conservative in changing the TKI. So I don't know if I have answered the first point of Dr. Ephraim. The recent evidences are pointing to being a little more conservative, particularly for the patients who are continuing to show a slow, steady decrease in the BCR ABL, particularly for the patients who are slow responders. So if you don't label this patient as a patient of imatinib resistance, then possibly a kinase domain mutational analysis is inappropriate at this time because you're not calling the patient as a patient with imatinib resistance. And then again, I think we've already talked about this, the bullet point number 3. No, I would feel that as per the current recommendations and as per the new data in the sense that large data sets from MD Anderson and the German CML4 study, when we have 10, 15 years survival data available now, uh, uh, possibly another good option for this patient would have been to continue the same treatment for another 3 to 6 months and then do a BCR ABL, and maybe you would have had the same molecular response at that time as the second generation TKI. And of course, individualization is the buzzword today. Treatment has to be individualized for each patient. The existing comorbidities have to be kept in mind. The kinetics of molecular response is very important. And that is the reason why most experts advocate that in the first year, at least at 3 months time point, 6 months time point, if possible 9 months, but certainly 12 months. So 3 to 4 testings, particularly in the first year, are very important. And then the aim of the treatment is extremely important for a 39-year-old patient. I would hesitate to start the patient on nilotinib because of the incidence of cardiovascular complications, which may be as high as 25% after 15 or 20 years of exposure to nilotinib. So individualization is the buzzword, and each and every single patient has to be looked at in a different way. Patients, female patients who are young, desirous of pregnancy, they have to be approached in a different way. Patients with comorbidities have to be approached in a different way. And each and every patient has to be individualized with the therapy which you go. And again, the buzzword in this fresh 2025 ELN guidelines is uh, a little more on the conservative side. Go slow and steady. So if there are any other inputs from anybody, then they're most welcome. Professor Nadeem Chaudhary is there as another expert on this, and we would very much value his inputs on this case and some of the points, some of the questions that Dr. Ephraim has raised. So are you there, Dr. Nadeem? Would you like to come in? Would you like to comment?
Well, thank you very much for, I think, Dr. Malhotra, you really put everything in a very nice context, especially in the ELN 2025 guidelines. And this is what we have been doing actually for many, many years. But I think ELN also came up with all these things because in real life, the practice is different from what the previous the guidelines always told us to do. And actually, I never followed that 3 month thing because it was too tight. And we all felt it because in our practice, it was different. I think I fully agree with you. I think the kinetics, as Dr. Ephraim showed, that was continues to decline, although it was more than one at 1 year. Retrospectively, I probably, if it was chance, I would have continued, but I guess nilotinib is okay. Although I do feel that a 39-year-old with nilotinib, if he's going to use it for a longer period of time, would be at risk, and to put them on, even on aspirin, I put all of them. But if you want to put them on some sort of statins, would that not be, and I mean, that would probably not be justified because those have their own side effects in a younger patient with decrease in the cholesterol and other effects on the other hormones, especially testosterone and other things. I really don't have anything. I think this is an excellent case in the context of resource restriction and the follow-ups, and it was very well actually carried on with the patient and the way it was treated. Except probably retrospectively, I would have continued imatinib, and we have seen even from the Iris trial that patients who achieved a major molecular response at 18 months or 2 years did very well actually. So they overcome or they overcome the previous effect that they used to say that at 6 months, 3 months, the response was in the warning area. So they overcome that adverse event if they achieve a MMR at any time within the first 2 years. So that's my
I
point.
think, yeah, that's right. Professor Nadeem has made very important inputs and comments. We have a couple of questions on the chat box. Maybe I can address those. There's one question from Dr. Hemant, and he wants to know why was the patient not considered for high-dose imatinib. So, like, first of all, there is a question mark whether this patient had imatinib resistance or not. So, if we presume that the patient had imatinib resistance and a change of treatment was needed, then you had the option of increasing the dose of imatinib, or you had the option of switching to a second generation TKI. And for patients who have imatinib resistance, the chance of increasing the dose of imatinib and it producing a molecular response at 10 to 15%, 10 to 15%, and shifting to a second generation TKI, the chance of producing a deep molecular response are almost 40 to 50%. So if you have the availability of a second generation TKI, then that is the preferred way to go. If you don't have availability of second generation TKIs, and if there are economic issues in the patient arranging and taking second generation TKIs for a long period of time, then a trial of increase of imatinib to 600 or 800 if tolerated is justified. The second question is, why was nilotinib chosen ahead of the other second generation TKIs? I think we've already discussed it. If I were treating this patient and if the patient had imatinib resistance, I would have gone to dasatinib rather than nilotinib because this is a relatively young patient. And if we have to expose the patient to prolonged periods of nilotinib, then there are significant chances of cardiovascular complications. Not that dasatinib doesn't have long-term complications, but possibly serious complications with dasatinib or less. So I think we need to move to the second case now. So I'm handing over back to Dr. Ehrem. So Dr. Ehrem, please present your second case. And let's be a little quick on this so that we have enough time to discuss TFR also. Thank you.
Okay, thank you, Professor. So we will proceed to the second case. And this is about a 26 years old female patient whom we have diagnosed with CML chronic phase in mid-2023. She presented with symptoms of anemia, left upper corner discomfort of 6 months duration. She had a very high white cell count, a moderate anemia, thrombocytosis. CML chronic phase was diagnosed. After cytoreductive therapy, we started imatinib 400 milligram daily. She achieved complete hematologic response within 2 months of therapy. And it was not possible to determine the BCR ABL level now for this patient because of economic limitations at 3 months. But she well tolerated the therapy and she was well adherent and she was in a complete hematologic response at 3 months. So we continued the same dose with close monitoring and we continued updating her CBC at 4 months. And 6 months, the patient stayed in a complete hematologic response. And we determined the BCR ABL now at 6 months of therapy, and it was 2.2 percent, and we continued the same dose of imatinib. The value was above 1%, but she was in a complete hematologic response, so we continued the same dose of therapy at 8 months and 10 months. She was still in a complete hematologic response. By 12 months of therapy, we again updated the CBC. She was in a complete hematologic response, and we determined the BCR ABL. It was 0.87. It was less than 1% by 12 months of therapy. So with a consideration of a complete cytogenetic response, we continued her on the same dose of imatinib 400 milligram, and we continued follow up every 3 months till 2 years of therapy, and she maintained her complete hematologic response. We are not able to do the BCR monitoring more closely and more frequently because of the limitations, you would understand. And by 2 years of therapy, again, she was in a complete hematologic response. After 12 months, we repeated the BCR ABL. Now it is 0.47%. And she was well adherent to the treatment, and there were no intolerances were reported. And she's a mother of one child. She's married. She doesn't have any recent plans to conceive, and she doesn't have the need to try TFR. So with the consideration of complete cytogenetic response, CML, we continued her on the same dose of imatinib 400 milligram. And our plan is also to continue on the same line of imatinib, and we'll continue follow up every 3 months, determining her BCR ABL every 6 to 12 months. So in this particular patient, the issues we are having, the patient tolerates the therapy very well for the past 2 years, and she was in a complete hematologic response. And her BCR ABL, as you have seen, it was not optimal by 6 months of therapy, but after that, after a year of therapy, it was less than 1%. It was showing a progressive steady decline from 0.8 to 0.4 now by 2 years of therapy. So the discussion points that I would like to raise in this particular patient is going to be a quick discussion. Is that should we really worry about patients who don't achieve major molecular risk? The BCR ABL is still above 0.1% is the first point. And if we change the therapy now, or if we wait and change the therapy by the time the patient has a failure to second generation TKI, is the long-term outcome is going to be significantly affected, is the second point. And since her BCR ABL, she has responded, but still she didn't achieve an MMR, is high-dose imatinib going to be beneficial in this patient in the absence of regular access to second generation is the other point. And if this patient wants to conceive or wants to try TFR at some point in her life, considering the fact that she didn't achieve an MMR, shifting to a second generation TKI to achieve a deep molecular response, is it going to be helpful, or should we continue on the same line of imatinib and hope that this patient would continue to have the steady decline in the BCR ABL that she's having at the moment? These are some of the points that I would like to discuss. Professor Hemant, back to you.
Okay.
So
Thank you so
much.
Thank you, Dr. Haile. Prof would answer the questions. I've encouraged people to put their questions in the chat so that as soon as Prof gives us his insight on the questions, we'll move to the second topic so that once we make up for time, we can come back. And please, I will encourage our resource persons to also answer some of the questions in the chat so that it would help with time. Thank you so much, Dr. Haile. Prof. Malhotra, what will be your take on these questions? Thank you.
So thank you, Emma, for coming in, and thank you, Ephraim, for the nice case. And this is a patient which exemplifies almost 1/3 of the patients in low middle income countries. So if you start the patient on imatinib 400 milligrams, 20 to 30% of your patients are going to be in this group. And I think, again, when we analyze the long-term data sets from the CML4 German study and the large cohort of the MD Anderson Cancer Center studies, and Dr. Kantarijian has recently published this also, the point of concern would be if at 24 months, the BCR ABL is between 1 and 10. And the fact that the patient is not in MMR, meaning the BCR ABL is not less than zero point 0.1, that is not a point of big concern because these large data sets tell us that about 20 to 30% of patients are going to be in this subgroup. And the chances of these patients going into an accelerated phase or a blastic phase is very, very small. And they will have a 80 to 90 to 95% 10-year disease-free, non-progressive, non-acceleration, non-blast phase survival. So it's not a very bad situation to be in. Only if the patient desires immediate pregnancy, so like in the next 1 or 2 years, then you would be justified in shifting to a second generation TKIs and trying to achieve that deep molecular response and attempting a TFR. But it is very possible that this same patient, after 3 years of exposure to imatinib or 5 years of exposure to imatinib, or 8 years of exposure to imatinib may go into a deep molecular response, and then you can have an opportunity for attempting the TFR. So, as you know, that TFR could be a goal for, should be a goal for young patients, particularly female patients desirous of children. And if that is a goal, then a quicker shift to a second generation TFR is needed. If that is not a goal, immediate pregnancy is not desired, I would be very happy to continue this patient on this dose of imatinib, monitoring the BCR ABL carefully at every 3 monthly or at worst every 6 monthly. And if there is a 1 log increase in BCR ABL, then certainly you initiate the failure protocol, get a kinase domain mutation analysis done, and shift to a second generation TKIs. So I think in the interest of time, unless there are any burning questions or comments from anybody, we could go to the second case. So over to you, Emma. Thank you.
Thank you so much, Prof. Malhotra. Thank you so much, Ephraim, for those insightful cases. So please keep the questions in the chat box, and Prof. and Ephraim would answer it. And if we have time, we'll come back to it.